One of the newer treatments for prostate cancer is a new concept called focal therapy. I suppose it's a bit like lumpectomy in breast cancer. We have the belief that in some patients, a very select group of patients, the cancer in the prostate only occupies a small area of the prostate. And if we could just treat that small area and leave the rest of the prostate alone, it may be possible to eliminate the cancer without any side effects. The argument against focal therapy from many of my colleagues internationally has been their concern that other parts of the prostate may harbour cancer and therefore you'll be leaving some cancer behind. I think that's correct in many cases, but there is a group of people, maybe 15 to 20%, who appear to have localized prostate cancer. Our challenge at the moment is to be accurate in selecting those patients for that therapy at the right time. We're doing a lot of research at the moment in focal therapy, trying to use such techniques as multiparametric MRI and transperineal template biopsy, as well as genetic testing, to be able to predict which is the right patient to have focal therapy. The principles that underline focal therapy are the fact that we've learned that cancer that kills you starts in an individual area. If we only have one individual area, it seems illogical to treat the whole prostate and rather just focus on the individual area. This concept is called the index lesion concept. My aim is to be able to select the right patients who are suitable for focal therapy, clearly in a slightly older age group, because this remains relatively experimental at this stage until we have more data and follow-up of our patients. What we have established already is that it's safer, it has less side effects, especially to do with erection problems and urinary control issues, and it's reliable in eliminating the cancer from the area of treatment. Focal therapy has become a more accepted potential treatment in patients with prostate cancer. Clearly, very careful selection of the right patient is mandatory. Since 2013, we have now treated over 100 patients with focal irreversible electroporation, called the Nanoknife, in highly selected patients who have localized prostate cancer. We've done this in a relatively experimental, research-based setting, and we've had meticulous follow-up of every patient. We've been very encouraged by the outcomes of these patients to date. It's now 4 years since I started this current project, and we've learnt already, firstly, it's very safe. Secondly, it's very easy to do. It's a day procedure. And thirdly, we can reliably destroy the area of tissue we want to destroy. In addition, the side effects of this treatment are remarkably low. Nobody has developed incontinence, and less than 5% have had any effect on their erectile functioning. The patients that I've treated with focal Nanoknife therapy to date have been very, very satisfied with the outcomes. Not everybody has been perfect, and some have required a second treatment, which has been successful. Our aim in the future is to continue to follow up these patients, continue to select the right people for this treatment, and now we're going to introduce genetic testing of the rest of the prostate to see exactly who the right patient is for this treatment. This will be in addition to MRI scanning by one of the top MRI experts and template biopsy to be absolutely sure we're picking the right patient for this therapy. If we do pick the right patients for this therapy, then it will clearly end up being 3 groups of treatment. 1 will monitor you if you have a cancer that doesn't need to be treated. 2 will use focal therapy where there's a small localized cancer where we're confident it's not widespread. And 3 will use whole gland therapy such as surgery and radiotherapy if we feel confident that it's widespread and requires full gland treatment. Our initial experience with the focal Nanoknife program has shown an almost 90% success rate, even including our learning curve, not only in the upfront situation, but even in patients who failed other therapies such as radiotherapy. In addition, there's been not a single major complication. Every patient's been done as a day procedure, and the impotence and incontinence rates are negligible. Our results to date confirm the following. 1, it's safe and is done as a day surgery procedure. 2, the incontinence rate is 0. 3, the problems with erections are less than 5%. 4, the cure rate, or rather the disease control rate at this early stage, is about 90%. And 5, one needs to remember that this incorporates even our learning curve, so results will continue to improve. The future is to better select the patients and tailor the treatment to the cancer and make sure the margin of safety around the cancer is appropriate. And this will require further research, which we're currently doing. As with all our treatment modalities, we continue to publish our results in international peer-reviewed journals, often in collaboration with our American and United Kingdom colleagues. You may ask if you, who may have prostate cancer, are suitable for such a new, relatively innovative and safe therapy. The ideal candidate, in my opinion at this stage, is a person who's over 60, who has a Gleason 7 tumour, that is, not a 6 which doesn't need any treatment at all, or an 8 to 10 which clearly needs aggressive therapy. Somebody where it's only localised to one section of the prostate, as evidenced by the MRI and transperineal biopsy, and somebody who wants to minimise their side effect profile by avoiding surgery and radiotherapy. One of the great benefits of focal therapy is it does not burn your bridges for subsequent treatment with other therapies.